I figured out how to get approximately 99% of my patients out of pain immediately, and approximately are like, yeah, I'm not worried about SI joint, not worried about sacral dysfunctions, not worried about plantar fasciitis anymore, not worried about this, not worried about that. And that's how we want it. That when someone comes in to your office, you are not worried about diagnosing and treating it. And we can get there was a study done, I believe the US military did a study, and they said that physical therapists, I believe it was 78% accurate in diagnostic versus orthopedic surgeons was at 81% diagnosing. I don't like that. I think that we can do way better than that. And if you follow my diagnostic procedures on how to diagnose back pain, how to diagnose this, how to diagnose all this stuff, and all the social media platforms, you can oftentimes get to a diagnosis without even imaging if you just rule out all these certain, all the mechanical issues, all the things that you can rule out. There's only like one thing left, and therefore you can be pretty certain that that's what it is, and that's how I do it. So, I'm pretty accurate historically, diagnostically, but I have a system to how I do it. And I rule out what I can rule out, and there's only usually one or two things left, So anyways, that's the stuff that I talk about here. But I know that my students around the world are pretty accurate as well, that have been following me for a while and doing these methods, okay? So today I am going to talk about slap tears, superior labrum, anterior and posterior, okay? So slap tears are annoying for the patient and the therapist. If you ask me, it is a structural issue. They tore their labrum. They tore their cartilage. So what happens in a slap tear? The person has instability. So they tear the front part of their cartilage up in there. That makes the joint more stable. And then they have pain when they raise their arm up usually. It can throb in sitting, but usually it's when they raise their arm up, they can get this pinching or locking or grinding type pain. And they'll usually point right over the long head of the bicep tendon. So whenever I see someone point over the long head of the bicep tendon, immediately my head goes to slap tear versus labral tear. Occasionally, rarely, it could be a subscap attachment issue, like subscap tear, but it's mostly slap versus bicipital tendonitis. Now, the tests for bicipital tendonitis, I think, are terrible. The speeds test or whatever, this one, you hold it, it hurts. Like most people have awful posture, and therefore they get a tendonitis in here. If you touch anybody, just go up and touch people. People hurt on their bicipital, long head of their bicep tendon, So I don't like the special tests for bicipital tendonitis. I think the best way to diagnose bicipital tendonitis is to rule out a slap tear, which I'm going to show you how to do that, and then touch the long head of the bicep tendon. If it hurts, they have bicipital tendonitis. If it's like super tender to palpate and they don't have subscap tear, rotator cuffs intact, no slap tear, what's left? What's left is bicipital tendonitis. Now, if it's up here, which can actually refer down in here, it's more AC joint, okay? But that also has to be taken into account, the AC joint, but basically the 2 or 3 things you're thinking about with pain in this region are bicipital tendonitis, slap tear, and sometimes AC joint, because I've seen it refer down into here. So I usually can get them out of pain instantly with my myofascial method. Just boom, gone. Stimulate different areas of the body. My instant issue with the slap tear is that it's structural. So that's tough to treat when you have a cartilage tear and you're trying to treat it. I'll show you how I do it, but let me first show you how I diagnose this. Okay, so the diagnostic test is the O'Brien's test, right? So everybody remember from school, you have the O'Brien's test. Put the person 10, 50 degrees, and you go like that. If it hurts in here and then hurts less in here, then it's a positive test. And that means that they indicates a slap tear. But I don't like that test. I don't like that test alone. It's a good test, but I don't like it alone. And the reason why is because bicipital tendonitis hurts there too. And AC joint can hurt there too. You know, when you adduct, you know, you're shearing the AC joint, right? So there's a way that over the years that I evaluate these people, okay, and make sure that probably a 99% certainty in my mind that I'm right, whether it's a slap tear or bicipital tendonitis or AC joint. And I'm going to show you how to do that, okay? So, Inez, can you come here for a second? Okay, have a seat right up there for me. Okay, so, everybody know Inez, then away to physical therapy. So, a slap tear, the way that you evaluate it, turn your thumb down like that, 10, 15 degrees of adduction. Hold, don't let me push down. Does it hurt? Yes, they would say right here if they have one, okay? Right. And this, kind of long head bicipital tendonitis region. And then turn your hand over, hold, and if they say there's less pain there, technically that's indicative of a slap tear. Now, what I find, but you can also have bicipital tendonitis that hurts when people do this. And you can also have AC joint shearing with arthritis when you do this, okay? But what I find, the best way to diagnose this is you look them right in the eyes. And I am 100% focused on what's going on in their face when I ask this question. This is so important. And I ask them, when I do this to you, hold, and I look them right in the eyes, and I say, when I do this, do you feel like it's superficial, like a tendon or a muscle, or do you feel like it's deep inside the joint? And I'm looking into their eyes because I want to know how certain they are. If they're wishy-washy, then I'm wishy-washy, you know, in my diagnosis. But they're usually not. They're usually spot on, and they will look you right in the eyes and say it's deep. And when they say it's deep, then I'm like, yeah, it's a slap tear. And when you check these people on MRI with contrast, you'll find that they were right. So I find that question, looking them right in the eyes, is the most accurate way to diagnose a slap tear, because the patient knows. They know if it hurts straight through the joint. They know that it just hurts, you know, right over the bicep tendon when you hold them in the O'Brien's test. They'll say, no, it's more superficial, and they're right. But sometimes with the slap tear, they'll feel it straight through the joint, okay? But when you ask them that, you know, when you ask them, is it deep or superficial? They will tell you the answer, and they are always right, I find, okay? That is the best way I have found, thank you, Annette, to diagnose a slap tear, okay? Now, all right, so when it comes to a slap tear, you have instability. So when I see a slap tear patient in my clinic, I can get a bout of pain immediately with my myofascial method and some other methods, my electromagnetic field science that I'm working on. But that's a structural issue. So what I actually recommend is, I don't take insurance, and I don't see slap tears that much, but I don't take insurance. So I actually recommend, if they're going to try physical therapy, that they should use their insurance. Because, you know, because it may work, it may not, you know, or help a little bit. I find maybe it'll help 10, 20%. So you have them hook up. The main exercises people do is put this in a doorway, right? And you can do oscillating external rotation. So you're trying to create stability. You're trying to teach the muscles to act like a ligament, right? And then you go like, hook it up into a doorway and go that way, internal oscillating internal rotation, right? And then you can do empty can underneath my foot, pin your shoulder blades back and down. That puts a lot of stress on your shoulder. Pin your shoulder blades back and down and oscillating, scaption, that kind of stuff, right? But the person will need to do this the rest of their life, okay? Because they will always have this pain in there because they have a structural issue, okay? So what I actually tell my patients to do is, I'm like, you could try physical therapy, but stem cell and PRP are actually showing great promise in healing people. Having people heal themselves versus someone healing them. So it triggers your body to heal itself. So I tell my patients that you should try PRP first, which is the less sophisticated form of stem cell. It's your own blood. They spin it up, inject it into it, and it works for, it's a coin toss. It's a lot of money. And insurance doesn't cover it, but it's a coin toss, whether it works. But for a lot of people that tell me in here, no, it worked. I had it done on both shoulders and it worked, right? And then I say there's a more sophisticated version, which is stem cell, and it's a lot more money. It's usually thousands of dollars, right? And I say, then you should think about that, okay? So PRP, then stem cell, then I say, if that doesn't work, you should think about getting it tacked back down by a surgeon, right? That rehab is a finicky rehab, and, can take 4 or 6 months, something like that, right? So I always try to get the body to heal itself first before any surgical intervention, unless it's an emergency, right? Because the body has an extraordinary ability to heal itself. It knows how to do it. It just, needs the right modality, if you will. In that case, PRP, stem cell, something like that. So that's how I advise my patients with slap tears. You can do the rehab, but I've been a physical therapist 20 years, and I've never seen somebody that was like, yeah, thank God I did physical therapy for my slap tear. All my pain's gone and it never came back. I've never seen that happen because it's a structural issue. It's like having a, ACL tear, right? Yeah, you can strengthen your hamstrings, right? But you got to do it the rest of your life, and it's still going to be unstable, So it's one of those things. What do you do, right? So that is how I diagnose slap tears. You need to look the patient right in their running legs, right in their eyes, and focus and look at the level of certainty in their eyes when you say, is that deep or is that superficial? Does it feel like a tendon or is it deep inside the joint? The patient knows. The patient knows, and they are more accurate than anything I've ever seen, right up there with a contrast MRI, I've found. And that's how I diagnose that, okay? So always look at the patient and ask that question because they will tell you the answer. When people say I listen to patients, no, really, listen to them. They know what's wrong with them. Just today, I had a patient come in and came in with a binder this thick of all the things she's tried for SI joint, for low back pain, right? And they keep telling her it's this mild herniated disc in her back, the reason why she can't stand up. And I'm like, that's not true. As soon as I hear that, I'm like, that's not true. You can't stand up from a mild herniated disc, come on, but they don't know what to say because that's what we do. We look at pictures, all day long. That's what the medical system does, right? And when I evaluated her, sure enough, I knew what it was before I even touched the woman, is because she had SI joint dysfunction, sacral torsion, sacral shear. Because Apple Podcasts, YouTube, I have a whole library of videos on YouTube I've had for years on how to diagnose conditions, get them better, all that stuff. I go through it all. Tips, tricks, everything, and then my papers are on my website, and all my courses are online. Anyways, peace, love you all.